Welcome back to the PIBD Digest, the podcast where we explore the world of pediatric IBD. And each week we invite an expert guest to join us in examining a topic close to their heart. I'm Dr. Tracy Coelho, and as ever, I'm joined by my co-host, Dr. Chris Bakewell. Hey Chris, have you noticed that our pre-guest chit-chat is getting shorter and shorter?
Yeah, but isn't that the natural progression of any relationship? At some point you just run out of things to say. And either way, you know as well as I do that this isn't about us. We started the podcast to talk about IBD in kids, and I'm sure our listeners would rather hear from our guests talking passionately about what they're, deeply interested in than to hear us harping on.
I think that's true, or maybe we are just evolving into a more efficient podcast species. Well, today we have to be very direct. No time to waffle, and we are going straight for the gut.
Don't like that. It sounds a bit too serious, Tracy. No teaser today, no mysterious build-up, or at the very least, a Maharaja's welcome.
No, I don't think we have a Maharaja's welcome. But there is a teaser, and we are going deep into the intestines, literally and genetically. Think high precision, possibly German-engineered guts, and high-end gastrointestinal science.
I'll take the German engineer as a clue then. Tell me what else.
Well, our guest is of German origin, and may I just say that he brings both high intellect and altitude to the conversation. I have met him several times, and every time I meet this guy, the ceiling gets lower and lower, and I hear that he has never used a ladder to change the light bulb.
I hope he doesn't mind us harping on about his height, but I think I'm getting a sense of who this might be. And to carry that on, it sounds like he might be tall enough to give us a helicopter view of today's topic, and indeed sharp enough to zoom right into the microscopic view of today's topic, which is monogenic IBD. And of course, that is IBD caused by a single gene or single gene mutations.
Yeah, for sure. And today he's guiding us through the fascinating twisty helical world of monogenic IBD, where one genetic glitch can throw the whole immune system into turmoil.
Right then, I guess we'll not delay any longer. I think it's time to welcome this towering titan of tiny mutations, the high priest of high-risk genes. Please welcome to the podcast, Dr. Jochen Kammermeier. Welcome, Jochen.
Hi, Jochen. Welcome.
Thank you, Tracy and Chris, for having me on your podcast.
So for our listeners, I'll just do a bit of background for you, Jochen. You are a consultant gastroenterologist in paediatrics based at the Evelina Children's Hospital in London, which, to those who don't know, boasts a pretty exceptional view of the Houses of Parliament. Whether that's a good thing or a bad thing nowadays, I'll leave you to decide. You are nationally recognised as an expert in early onset and monogenic inflammatory bowel disease, and in particular, the use of genomic medicine to diagnose and manage complex immune-mediated gut disorders in children. Would you say that's a fair introduction?
Well, that's a very nice introduction. Thanks so much, Chris. Yeah, I like it so far. Bring it on.
So before we jump into the well, I'll say heavy topic, but hopefully, light for the audience of monogenic IBD today, would you be able to just give us a little bit of background? Tell us, what drew you to focus on monogenic IBD and your journey maybe into pediatric gastroenterology?
Oh yeah, of course. Yeah. So I started the journey early, if you don't mind. So I was literally born in a tiny little village in the Black Forest. And I was never one of those, children who, I don't know, with 2 or 3 years of age knew they would really want to become a doctor. So I was really going all the way from wanting to become a gardener, landscaping architect, geoecologist at some point, biologist, and then eventually even a veterinary doctor was something I was really interested in. And then finally decided to become a pediatrician. So I studied in Heidelberg, which is probably quite known university in Germany. And then for my final year, went to Mexico. I studied in Mexico for 1 year, completed my MD thesis in pediatric oncology when I returned to the University of Heidelberg. And then really very non-scientific, just followed my girlfriend and now wife to England. So that's how I ended up in England. So did my general pediatric training in various hospitals around London, then got onto the grid, specialist training for pediatric gastroenterology. And that was obviously absolutely central to what happened next. So I, first of all, confirmed that, and I'm sure you guys would agree, pediatric gastroenterology is by far the best and coolest topic, in pediatrics. Secondly, so I met lots of friends, colleagues, and mentors who were crucially influencing me then in what happened next in my career. So I was in Oxford for a year, and I met, who I'm not sure whether he gets annoyed with this, but I call him the godfather of mucosal biology and PIBD pathophysiology, Professor Ullig, so Holm, who has been a great mentor to me and a friend ever since. And he really sort of ignited my interest in monogenic IBD at the time.
Of course, Holm Ullig should be mentioned. I trained in Oxford as well, so he's certainly a prominent figure. And everywhere you look in the literature on this topic, especially, his name crops up, and many other places as well. So perfect, thank you.
And then in my final year at Great Ormond Street, I was given the opportunity by, at the time, Mamoon Elawat, Nikhil Thapa, and Neil Shah at Great Ormond Street, to embark on my PhD on genotypes and phenotypes of IBD in early childhood. At the time, also supported by Professor Beals at the ICH. So it was a really amazing time for me. And then, after that, moved to Southern Shores, as you said, to the Evelina Children's Hospital, and have, over the last 8 years, led the IBD department there. I suppose my special interest remained, again, so very early onset IBD, monogenic IBD. I do lots of transition as well, so the IBD transition. And this was the latest kit on the blog, which I'm really enthusiastic about, is intestinal ultrasound.
Really nice. Quite a few interests there. So, Jochen, we have talked before on this podcast about the genetics of IBD. And as we know, monogenic IBD is very different from polygenic IBD. Now, for our listeners who are not very familiar with monogenic IBD, do you want to shed some light? What is monogenic IBD?
Yeah, of course. So obviously, we kind of know from, GWAS studies over the years that obviously there is an accumulation of certain common genetic risk variations, that can contribute to the overall disease risk, of inflammatory bowel disease. In contrast, monogenic IBD really describes a scenario in which a single gene mutation causes IBD, and that's obviously very different to our, I suppose, concept of IBD in general. So we find these mutations in genes that are sort of often involved in pathways of the innate adaptive immune response, immune regulation, phagocyte function, and epithelial function. So it is different to classic polygenic, conventional IBD, whatever you want to call it. And I suppose, interestingly, when we first came up with that concept also, people would always say, but that's not really IBD. And I'm sure you guys have heard this as well. Monogenic IBD is not really IBD. But I suppose it comes back to a very generic question. I mean, what is IBD, isn't it?
Yeah, and I guess it's rare, right? So most general pediatricians, if there are any general pediatricians listening, may not have come across it in clinical practice. But if you do a bit of reading about it, what jumps out is these very early onset cases. Would you just be able to paint us a clinical picture of the typical monogenic IBD patient, the clinical history and the phenotype you'd expect turning up to your gastroenterology clinic? And I would say, from my understanding, they're not all young. I think the oldest patient I saw on some work that I think you were involved in was maybe around 60. They're not all babies.
No, absolutely. You're absolutely right, Chris. Yeah. So I suppose it is difficult to say what the monogenic IBD phenotype is, isn't it? Because we have now established approximately 100 plus, genes or monogenic IBD conditions. And obviously they're all quite phenotypically heterogeneous, isn't it? So it's not that they all look the same. So, and as you rightly said, Chris, so about 60% of monogenic IBD presents before their 6th year of age. So that's certainly the majority. But there are 10% that usually present in adulthood. And that comes to one of the topics we might discuss later as well. And that is, the awareness of monogenic IBD has to be really across the pediatric and the adult specialty range. So our adult colleagues need to be aware of that condition as well. Now, I would say typical monogenic IBD, I suppose the seminal publication in 2009 and 10 on IL-10 receptor and IL-10 defects would describe this sort of typical infantile onset patient prone to bacterial infections, a very severe perianal disease and colitis. So that would be sort of a classic presentation of an IL-10 receptor or an IL-10 defect. But there's others. Probably the three most common ones that have been reported so far are IL-10 receptor and IL-10 deficiencies, ZIAP deficiency, that's X-linked inhibitor of apoptosis deficiency, and chronic granulomatous disease. So these three are by far the three most common reported monogenic diseases. As I said, IL-10 presenting with this sort of very nasty, severe perianal disease and colitis. ZIAP deficiency is a bit more difficult because, first of all, it can also present later. The majority would present in early childhood. They're prone for developing sort of severe viral infections as well, so often EBV, which then, and that's obviously the most dangerous part of the condition, can lead to sort of HLH or macrophage activation, which is obviously a lethal a problem these patients can encounter. But they also have fistulizing and perianal disease. And then finally, chronic granulomatous disease, again, would usually present, via our colleagues in the immunology department. Often these, they have sort of complex bacterial fungal infections, present probably a little older than the two others I mentioned. Would again present with a much more sort of Crohn's disease-like phenotype. And again, even those can present with perianal disease. So I suppose if you have a child presenting very early, severe perianal disease, that would probably be the very first sort of red flag one would look at. But there's many other sort of phenotypic features that one need to consider when we're looking at these children.
Mm. And you mentioned just earlier, monogenic IBD. Well, that's not real IBD. And I suppose part of that maybe is because the immunologists and people that would manage disorders of the immune system may see these children first, or may see these children for a long time before a gastroenterologist gets involved. And of these 100 or so genetic disorders, mutations that have been identified, what proportion would be immunodeficiency? Are they all immunodeficiency disorders, or are there some that don't seem to impact the immune system but do give you this early onset IBD phenotype?
So, Chris, before I come to that, there's something else you mentioned which is absolutely crucial, and that is because the majority of these children historically have been primarily seen by the immunologist. You often, particularly when you're looking through some of the published data, you actually see that people often haven't even looked at the sort of gastrointestinal phenotype, because people weren't, with all due respect to our immunology colleagues, they're not particularly interested in the gut, and most of them. And often it was in one of the studies we did in 2014, led by Holm at the time, we were looking at all these individual phenotypes of the conditions known. And it was very, very hard to actually establish whether these children had a GI phenotype, because it was really hardly ever reported.
Yeah. So my question was, I suppose, given that so many of the genes that we know about are associated with the immune system, is that a commonality of all monogenic IBD, or are there some that don't seem to affect the immune system but do give you this early onset GI phenotype?
So I would say the vast majority have a form of immune deficiency or dysregulation. There are sort of some probably that have less of that, but to have a monogenic IBD that does not have autoimmunity, not have immune dysregulation, not have immune deficiency is probably rare, is probably not that likely. Because even you could argue, even some of the epithelial, defects, even those, directly or indirectly, are somewhat immune deficient as well.
Yeah, sort of mucosal immunity rather than maybe systemic. But so when we were researching this podcast, as diligent podcast hosts do, I was terrified, obviously, because you are, very knowledgeable on the subject, and I am definitely not as a final year Peds Gastro trainee. So I came across your brilliant publication in 2023, the joint Busbegan BSG consensus guideline on managing and diagnosing children with and adults with monogenic IBD. Firstly, how did that come about? You were the first author. Holm Ulig, as we mentioned earlier, I think was senior author.
Father and son, yeah. So that's a question. So basically, the journey of again, I can't mention Holm enough, but I think I've done it enough now. Just I can't and also thank Holm enough for everything he's provided to the community. So the journey is sort of to look at genomics and IBD started obviously years before. So we have at Great Ormond Street we've published the first targeted gene panel that was available. The Tiger panel at the time, our famous Tiger panel in 2014, and many different publications followed on from that. And I suppose the idea Holm and I had, and I remember that was during a Espegan IBD masterclass. We kind of sat together and we said, look, it would be really nice, first of all, to combine all that information that we've gathered and all that data we've gathered over the years, and also, as we highlighted before, really bridge that gap to our adult colleagues as well, because it became apparent that, as you rightly pointed out earlier, this is not a condition unique to the pediatric population. So there was certainly a need to do that as a combined guideline, from BSG and Busbegan. And so we kind of started from there. I suppose in parallel, we obviously had the possibility to now screen or genetically screen patients via the NHS. And this all came together and we felt, look, there's a real unmet need to produce a document, that sums it all up.
Yeah, and I would really urge people to read that. It's fantastic. And although it does acknowledge in many cases that this is consensus without a huge amount of evidence, I think there's some content in there that's really, really clinically very helpful for managing these patients, and some information that you may not have addressed or thought about in the very specific nature of how these patients present. One of the things that really stuck out for me was these maybe young adults, teenagers with very severe perianal disease, who may be undiagnosed SIAP or chronic granulomatous disease, and it just hasn't been specifically thought about. And that's just something I would never have thought about that personally in my practice until now. So yeah, really do read it.
No, I think, absolutely. And there is, I suppose, what was really nice, particularly in the development of that guideline is, obviously you see my, the first author, Chris Lamb, Professor Lamb from Newcastle, he's been an amazing help. I'm sure most of you know him as well. He's an amazing person, and it was really nice to kind of bring him on board, and I think sort of ignite his interest in monogenic IBD as well. And you'd be surprised how often you join adult forums and talk about monogenic IBD, and you just been looked at and going, what are you on about? What are you talking about? And I think it's nice to see that the adult community is getting more and more interested. The same applies to my team here, at Guy's St. Thomas. Obviously, I work with amazing adult IBDologists, who have a huge cohort and great reputation across the UK and internationally. And it's really good to see that they're very open to working together, open to picking up some of the things that we as pediatricians might know a little better. And that doesn't happen very often,
Yeah, we've got to hold it above them some way.
Absolutely.
I was about to say that we shine like dazzling stars when it comes to genetics of IBD.
Nutrition as well, Tracy. I think we're better. I think we're better in nutrition as well. And not me personally, but certainly we as a pediatric community.
Yeah, sure. Yeah. So I was very impressed about the well-deserved shout out to Professor Ulik. I just wanted I had one question, slightly non-medical. So when you speak to Professor Ulik or home, do you discuss genetics in German or in English?
Oh, wow. Yeah, that's a very good question, Tracy. So I think we both have the same problem that after sort of a long working day, you'd be surprised. It's much easier for me to stay in English than actually, talk German. The same to my kids. And then we kind of end up in this sort of Denglish weird mix of words, mixing and matching everything together. And I think Holm and I, we have the same problem. So sometimes we sit there, and focusing and, hey, we should say something in German because obviously we're both thinking of it. And it just ends up in this weird mix of random sentences, So people might look at that and feel slightly,
I'm sure people will get that. So, Chris, you mentioned about the immunology, gastroenterology bit of monogenic IBD. What I wanted to ask Jochen was, suppose let's give a scenario. Suppose there's a patient who is diagnosed with, let's say, IPEX syndrome. Who owns the patient? If he has a bit of gut symptoms, is it the immunologist, or do they say actually is falling in the gut territory now? Do you want to own him? And how does the collaborative approach work?
So that's a super good question, Tracy. And actually, you can add to that, just to make it even more complicated, depending on, for example, which country you work in. People would see exactly that in a completely different way. So I think in the UK, believe it or not, I think we are super fortunate to have this sort of very, very strong MDT mindset. And I know it sounds a bit like a hollow phrase, but I truly believe in it. I've worked in other sort of settings where that wasn't the case. So I suppose it's not only who looks after that patient in your institution, because it might be another place, across the UK who has a, better, expertise in one specific individual condition, trichoepithelial syndrome, might be looked after somewhere very well. So I think the first question is, whenever you're looking at a patient, to maintain that sort of MDT mindset, to make sure that not only you pull in all the expertise you have in your own institution, but to actually pull in expertise, from other places as well. I don't think there should be any sort of pride of any kind of saying, hey, this is my patient, I look after this patient. And I suppose I can tell you from own experience, although it's not IPEX, if you don't mind, from a SIAP patient, I really felt that as long as everyone respects their expertise within their area, I think it works really well. So we work very closely with our immunologists, actually in-house, but also at Great Ormond Street, and they respected very much our expertise in handling the sort of GI aspect of SIAP, for example.
Yeah. I don't want to keep harping on about your guideline, but that is one of the strong themes of the guideline as well, how important it is. I mean, very specifically about, getting the diagnosis right, but also it holds true for throughout management, how important it is to not rely on one area to kind of pull together shared knowledge, and because these children don't have a lot of phenotype data, there may not be many patients that have had this condition diagnosed before. So you're working with a small amount of information in any case. So pooling together to experience would surely be the way to manage them. Otherwise, you'll come unstuck if you're trying to lead from the front without listening to anyone else. And geneticists, of course, play a huge role.
And Tracy, I want to add one more thing, and that is, it might not only be sort of clinical expertise. You might even have to venture towards research. There might be someone who's actually working on something, either in the UK or internationally, and you want to kind of pull in as much information or data as possible to kind of support your patient there, and particularly because these are exceptionally rare conditions.
Yeah. Jochen, I know we keep orbiting around your very influential paper. I'm not sure if you're aware, we had established a monogenic IBD clinic here in Southampton, and at the time we were wondering how the genomic testing would be funded. And soon the R15.4 panel became available through the NHS Genomics Test Directory, and I'm certain that your paper played a key role in supporting this development. Could you remind us how many genes are now included on the panel?
No, absolutely. So we kind of touched on this before. Obviously, there is a Genomics England sort of panel app, which is sort of, as you might be aware, from a repository of many different gene panels, and they're usually curated by experts, sort of groups that initially sort of draft using known gene lists, from trusted sources, and experts. Then specific registered expert reviewers look at these gene lists and sort of gather evidence, rate the genes, suggest certain sort of additions, leave comments and things like that. And then there are final sort of panel curators that would then finalize the panel list, and the green graded genes are then sort of diagnostic grade genes with very strong evidence behind them, and they are then also used for clinical reporting. So the R15 panel has traditionally, and interestingly, that's the same we did with the Tiger panel at the time, because of the significant immune deficiency overlap. These panels have traditionally been sort of primary immune deficiency monogenic IBD panels. As far as I'm concerned, the most recent update I got is that there are approximately 365 genes on the current panel, and they obviously include, PID and monogenic IBD genes, and they contain all the Espegan position paper 75 monogenic IBD genes, and there's obviously an ongoing, I suppose, there's an ongoing plan to update these genes, and every new gene that comes onto the market or is known to us will be included. So we do know about so roughly 100 plus genes now, and the R15 will contain the majority of these genes.
Okay. So as pediatric gastroenterologists, we diagnose with patients with IBD when they are maybe 2, when they are 4, 6, 10, or 15. So when should us as clinicians suspect monogenic form of IBD and pursue genetic testing? That's number one. What are the implications of diagnosing a child with monogenic IBD in a family? And is there a role for predictive testing? Sorry, I'll repeat my questions if there are too many.
Yeah. This is a very specific Tracy technique to ask you 3-in-1 questions. But
Tracy, yeah. So after 10 hours on call, you might have to kind of split that up a little bit. So again, you know what? I'm going to start, Tracy. I'm going to start with the most important thing. Yeah, I think the really most important thing, one, and again, we're getting bored to refer back to the guideline, but I think the actual criteria for genetic screening are probably the most important. sort of facts, we bring across. So basically, all children under 2 years of age who have IBD should be really screened for monogenic IBD. Now, there is some, I don't think I've mentioned this yet, so Holm and I are also working on some epidemiology sort of data that we want to kind of finally publish this year on sort of monogenic IBD epidemiology. And we think, although obviously I can't give you the exact data yet because it's all super secret at the moment. So we think that probably in the first year of life, children presenting with IBD have a chance of about 15 to 20% of being monogenic. And that doesn't sound a lot, but in the greater scheme, that is actually a lot. This dramatically drops, even from the second year onwards in the total pediatric population. Prevalence will be around sort of 0.3%. That means sort of, in 1,000 kids, 3 younger than 16 will have a monogenic IBD, a form of IBD. So the criteria certainly screen all the kids younger than 2 years of age. Be very, have a very low threshold for screening children presenting younger than 6 years of age. And then there's these additional criteria that we listed, namely, infection susceptibility, or if you're really thinking, hey, there are some abnormal laboratory tests, that are suggestive of an inborn error of immunity. So obviously screen those too. Then other phenotypic features that you're worried about, we mentioned previously, complex autoimmunity or a macrophage activation syndrome, so these sort of things should really point us towards really wanting to screen these children. There's a few super rare phenotypes that you'd have to screen: congenital multiple dysplasia, sort of TDC7A, cases where you really want to make sure you screen them just because of that, congenital diarrhea, family history, of monogenic IBD, of course, or suspected monogenic IBD, of course you would screen. And I certainly, from my own experience, we had one patient with SARD deficiency who presented in infancy, and as he was genetically diagnosed, we were told that actually his uncle had severe Crohn's disease, and at the time his uncle was already in his 20s. And when screened, he was actually found to have the same mutation than his nephew, who was diagnosed in basically in infancy. So yes, absolutely. So we should have a low threshold there. Now, early onset of malignancy in combination with IBD, you might have seen that as well. Obviously, that's a super rare occurrence, and that's mainly based on the fact that you can have untreated IL-10 patients who actually present, with certain forms of lymphomas very early. So you might want to have a low threshold for screening. And then last but not least, obviously, whenever you want to intervene with a irreversible procedure, whether that's poetic stem cell transplantation or anything of that kind, you kind of really want to make sure you have screened for monogenic conditions. One thing, if I can, I want to add, which is something we talked about a lot, and that is, what about sort of severity of disease? Because I'm sure you were going to go, hey, I've got this child, super severe IBD, so should we screen? Or therapy refractoriness, so this child does not respond to any therapy, so what should we do? It's a surprisingly unreliable signal for monogenic IBD, I have to say. And also, I suppose it is very difficult to define what it means to be refractory to therapy, isn't it? Because 10 years ago that meant not responding to infliximab. Today this means like not responding to 5 advanced therapies. So it's a feature that we took out of these hard criteria, but it's obviously something you might want to keep into consideration. And Tracy, as I absolutely predicted, I now forgot the other question.
Well, that's fine. Let's pick up on that point though, because so despite there's been a lot of advances as we've talked thoroughly about in diagnosing these conditions, and we've talked then about how you identify those patients. But even you've got to that point, they've been in the monogenic IBD, MDT, we are confident in the diagnosis. There's still a very tricky set of symptoms, and they're very tricky conditions to manage, even so. Often resistant to classic IBD therapies, not always, and not a good diagnostic tool, but still they are. How does the treatment approach differ? And of course, as you said, it's a heterogeneous group of disorders, but I'm talking specifically about things like hematopoietic stem cell transplantation or directly targeted therapies to the genetic disorder. Those exist?
Yeah, no, absolutely. So I suppose, so one thing to say, which I'm not sure if I mentioned it at the start, is, so it is obviously a fact that monogenic IBD, compared to non-monogenic, if I may say, non-monogenic IBD sounds to say, but non-monogenic IBD, obviously, has a poorer outcome. So these children are sicker and have a higher mortality. So monogenic IBD probably has a mortality. Again, this data is a little bit, patchy, but probably has a mortality around 15 to 20%. So these are really, really, highly sick children. And obviously the rates for requirement of these sort of high-risk therapies are obviously much higher as well. So the need for parenteral nutrition, the need for hematopoietic stem cell transplantation or surgery is higher compared to patients with non-monogenic IBD. That has been published by friends from the Poetic group recently, but that's some of the data I also published when we looked at this Great Ormond Street cohort at the time of infantile onset IBD. So I suppose that is a fact. So we know these children are difficult to treat and have a poorer sort of long-term prognosis. And often, Chris, when we talk about therapies, often people go like, yeah, but it's very few people, and it's not really much you can do, and that's obviously not true. I mean, we now know, for example, starting off with the with the classic monogenic IBD conditions, sort of IL-10 receptor deficiencies, they really, really have good outcomes from hematopoietic stem cell transplantations. We must never forget that it's a very dangerous procedure to transplant someone. And unfortunately, again, when I was at Great Ormond Street, we had a patient when the sort of post transplantation phase passed away, which was absolutely horrendous. So, we should never be blasé about hematopoietic stem cell transplantation, but the outcomes are really, really good, particularly for IL-10 and IL-10 receptor deficiencies. But there are sort of non-transplant therapies that one can use for some of the rarer conditions. So obviously I don't want to go into detail, but so LRBA, CTLA4 deficiencies. So these are other sort of conditions where you can now use a sort of synthetic protein, CTLA4 fusion protein, abatacept, to treat these. Then for example, for IL-10opathies, so ZIAP deficiency can be particularly sort of IL-18 predominant, and then tadecunic is one of these. Tadecunic alpha is a recombinant IL-18 binding protein that one can use to treat that. It doesn't mean it always works. So for example, our ZIAP patient at the time did not respond to that, but certainly you can start thinking of using targeted and personalized therapies to a patient once you have a genetic diagnosis.
And very specifically, Jochen, they're not treatments that you would give to someone with polygenic non-monogenic IBD. So if you know early enough in the course of the illness what the genetic disorder is, then you don't go down that other path, which then might lead to surgeries with failed treatments. You can start the process of targeted treatment earlier.
Absolutely, and I want to add one thing, and again, in most of my presentations, I it's in the past I use that side because it is so absolutely visual and kind of horrendous as well as a story. Again, the sort of Oxford group published this adult patient who was diagnosed sort of in the 40s with ZIAP deficiency, but has gone through decades worth of failed therapies, surgeries, admissions. And I know we should really, in that context, not talk about money, because that's not really ethically, highly questionable. But in the NHS setting, we sometimes have to talk about money. And if you think about the money that has been wasted and the harm that has been done to this patient, because we did not obviously have at the time the means to investigate or screen for genetic conditions, even more so, important to kind of have this in the back of our minds and making sure we think about monogenic IBD for various of these reasons.
Jochen, because of my streak of stubbornness, I think I will come back to my original question. So I was asking you about predictive testing in a family member. For example, you have a patient with a diagnosed with ZIAP deficiency. So implications for the siblings. Would the family come to you for predictive testing? What would you do?
Yeah, so Tracy, that's obviously super important. And that's where, again, I would call a friend. So I would basically, in this setting, and we highlighted that before, how important it is to have sort of purely genetic experts in that MDT as well. So for example, everyone who is diagnosed with a monogenic condition has to be referred to a geneticist for various different reasons, for, family planning also, family planning, family management, for siblings that, that are there. I mean, I gave you that example of that patient whose uncle, was affected, unknowingly for decades. So I think it's absolutely crucial to make sure that once we have done our bit, we then ask other experts to do this sort of purely genetic, part of it. I suppose in monogenic IBD, it's about 60-65%. There's a very, very good publication, a sort of a summary of all published monogenic IBD conditions. I'm not sure whether you guys came across that. That was led by Alexio's group, so Alexio Muse. He's the sort of Holm equivalent from North America, if there's such thing. And Alexio and some of his collaborators have summarized all published monogenic conditions between 2000 and 2020, and they established about 750 of those conditions. It was highlighted that not all, but the majority were autosomal recessive conditions. So there's about 60-65% of those mutations were autosomal recessive, it is obviously, in terms of genetic planning, in terms of family planning, it is absolutely important to involve geneticists in that process.
Okay. Now, suppose you have a patient diagnosed with ZIAP deficiency based on genetics through sequencing. So, as a follow-up to confirm that, do you do functional workup for this patient?
Yeah, no, absolutely, you should, and actually, you should probably do functional workup for every monogenic disease where functional tests are available, and that is not always the case. So I suppose that's it. When it comes to ZIAP deficiency, again, you would ideally ask, a friend, you'd ask, a group of people who are interested in these conditions, say, hey, where can I get some functional work done for ZIAP, for example, ZIAP expression? So how can I get this done? Our, immunology colleagues at Great Ormond Street, Kimberly Gilmore, she's an absolutely amazing scientist, who work at Great Ormond Street, who would be happily advising you, what the best functional test for any of these conditions are. And again, you would not find one single person who is an expert in everything. And there's absolutely no problem to say, look, this is not my area of expertise. I need to draft someone in who is. You might not understand everything. Certainly when I speak to Kimberly, I might not always understand what she's actually saying, but she's, incredibly clever, and she can certainly give you advice.
Nice. So Jochen, as pediatric gastroenterologists, we all have our special interests. Yours, for instance, being monogenic IBD, among many others. But for the rest of the generic gastroenterologists, do you think there's a knowledge gap when it comes to the genetics of IBD?
Yeah, I think, you see, it's difficult because that applies actually to all three of us. I have to really say, we kind of live in a bit of a sort of bubble, isn't it? Because for us, it's not only medicine, it's not only pediatrics, it's actually not only pediatric gastroenterology. Often we are also just kind of very focused on IBD in general. So I think the awareness of monogenic IBD absolutely, it needs some work. We need to actually, spreading the news. We need to make sure that people are aware of monogenic IBD. And I want to give you one very sad example, if I can. So I was recently talking on a monogenic IBD at the BSG conference in Glasgow. Now, it doesn't sound very happy, but actually our monogenic IBD and pediatric session was in parallel to presenting the new IBD guideline. You can imagine.
Big turnout, yeah.
There were that many patients, at our pediatric session, which is kind of sad. And as I was trying to convert our adult colleagues, and tell them about monogenic IBD, I think I was looking at probably about 15 or 20 faces who are very happy. But joke aside, we really need to make sure the awareness of monogenic IBD is there. We need to make sure that people are aware of it. We need to make sure that people actually know about the guideline, and I think also to ask, have a low threshold for asking, have a low threshold for screening. As we are screening more, classic phenotypes that we associate with certain conditions will become softer all of a sudden. And we know this not only from gastroenterology, isn't it, or from pediatric IBD or so. I mean, there's a classic gestalt of a sort of genetic, presentation from the old textbooks. And I can tell you now, again, I don't want to refer back to one of my very favorite, patients, who I saw here. The way how this sire presented was not a textbook sire patient at all. And it was really only the criteria-led screening for this patient that highlighted, the genetic mutation. And not that he presented. He, for example, did not have any fistulizing perianal disease at all. And he didn't have macrophage activation or anything like that. He just had infantile onset IBD.
Yeah. And I think, as I say, the phenotype softens, that we gain more understanding of the phenotype. Of course, the mortality is so high at the start because those are the sick kids that are getting genetic panels done as you establish. And it's quite nice to see, I guess, that these regional MDTs and the kind of network seems to be forming of managing these patients. You'll start to see more of a cohort of each of these more common and rarer genetic monogenic forms of IBD. So you start to understand the conditions better. And I guess that is a process that's difficult to speed up because until those children exist in a cohort, they're just not in the zeitgeist. They're not in clinics. They're not seen by pediatricians or gastroenterologists. So I suppose it's finding ways to speed up that process that's important. And the guideline is brilliant for that, I must admit. That, that's instantly I'm educated on it and I know.
Yeah, and I suppose the other obviously one is the awareness. Obviously of monogenic IBD in general, and then the other difficulty we have is because these conditions are so rare, and reporting is so heterogeneous as well because there's no sort of regulated way of reporting, and monitoring these patients.
Jochen, I think that's all we have time for today. Thank you for giving us all your insights into the world of monogenic IBD. Hopefully, our listeners have stayed with us to the end because this is certainly a very complex group of conditions, but it's clear that our understanding is increasing and now leading to the exciting targeted therapies. Is there anything you would like to add before we wrap it up?
Not really. I think you guys are doing an amazing job, and I really enjoyed this session. So yeah, let's have a big shout out to monogenic IBD and increase awareness. Yeah, And thank you very much for today.
No, thank you for this wonderful, engaging discussion. Thank you and take care.
Thank you. Take care. Yeah.
And as always, we can't end the podcast without indulging in a touch of poetic obsession. So today's finale is titled The Tale of Two Adversities, a poetic showdown between polygenic and monogenic IBD, with all their key differences wrapped in rhyme and science. The Tale of Two Adversities, blameworthy genes with milder infirmities when they collude as many. Polygenic disease is what we see, unkind, unpleasant, and of course uncanny. But single genes, when vilified at their critical positions, the events as these are odds of a much rarer disposition. Monogenic disease is what comes forth in nastiness of unruly proportions. When the brutal disease pops along in its scathing monogenic form, it's much harder to right the wrong, despite approaches so robustly unified and multi-pronged. With the shared gene functions propping the immune system in some way, the polygenic adversity is perhaps a storm sometimes, of a bit milder say. But when the monogenic disease strikes in full force of its disastrous play, there's anarchy and carnage, with the immune system in shreds of utter disarray. But regardless, with the advancing wisdom, hope and cure will come someday. I know skeptics listening today will throw a rent in their scornful dismay. Oh, nothing new, same old, as they always say. Thank you. Dear listeners, thank you for tuning in. I hope you enjoyed this episode. Keep listening, and we'll see you very soon. Bye-bye.